Association of Nigeria. I welcome you to this PAN webinar series 006 for the year 2025. Today's session is in collaboration with Pediatric Assembly Nigerian Thoracic Society. And the topic is childhood pneumonia, current perspective on diagnosis, management, and prevention. We all know that childhood pneumonia is a massive problem for Nigerian children in terms of mortality and morbidity. So today we have experts from the Pediatric Assembly to be speaking with us about it. And the moderator is Dr. Adeze Ayuk, one of the gurus in that region. So I welcome everybody, all PAN elders present, and PAN president, our own president, Dr. Ekanem Ekure. Welcome, Ma. Ma, you can go on with your welcome address, after which the moderator will take over. Madam President. Ma.
He's not yet in the room, so you can move on now.
Okay, so on her behalf, I welcome all our PAN elders, all our esteemed members to this webinar series.
Sorry, I'm here in the room.
Oh, great. Thank you, madam.
Okay, ma.
Please
welcome.
go on.
I've been here. Apparently, I was muted, so I actually started speaking. Okay, thank you. Thank you very much, Madam PE, the PAN Secretary, and other members of PAN ESCO that are in the room, the Pediatric Assembly Nigerian Society leadership, the moderator, immediate past PAN Treasurer, Dr. Adeze Ayuk, and speakers of the day, Dr. Muhammad Abubakar and Dr. Adefunke Babatola. PAN elders in the room, esteemed PAN members, both home and abroad, partners and friends of child health that are in the room, good afternoon. It is my pleasure to welcome you all to the July edition of our monthly webinar series, the 6th in our 2025 series, proudly hosted by the Pediatric Assembly of the Nigerian Society of Pediatrics. Today's topic, childhood pneumonia, current perspective on diagnosis, management, and prevention, is not only timely, but deeply relevant. Like we all know, childhood pneumonia continues to be a leading cause of preventable deaths in children under 5, both globally and in our country. And in the shadows of our health systems. As pediatricians and child health advocates, we must continually refresh our knowledge, interrogate our practices, and align with evolving evidence and innovations that improve diagnosis, clinical management, and above all, prevention. And this includes strengthening our use of vaccines, promoting exclusive breastfeeding, tackling air pollution, addressing malnutrition, and ensuring access to timely and quality care. As part of this process of tackling one of the risk factors of pneumonia, yesterday, I and the immediate past president of NISOM, Dr. Maria Mutayola, were in a meeting with the Director, Department of Pollution Control and Environmental Health in Abuja, where we had fruitful deliberation on how PAN can collaborate with them on improving air quality and child health in Nigeria. I commend the Pediatric Assembly and our resource persons for putting together this session. I encourage all of us to engage actively and take away insights that can enhance our everyday practice and advocacy. Together, let us reaffirm our commitment to ending preventable child deaths and building a healthier future for every Nigerian child. Thank you very much, and I wish us all a fruitful webinar. Over to you, Madam PE.
Madam P, you can continue.
Is she still in the room? Okay, just in case, maybe she's gotten off. I think the moderator can take over. So Dr. Ayuk, over to you. You can start moderating. Thank you.
Thank you very much. And thank you for the opportunity given to the society and particularly the pneumonia group. At this point, I'll introduce the chairman of the pneumonia committee, who will just say something briefly, and then also introduce the speakers, and then the talks can start. Dr. Sorogiabo Wilson, I know you're in the room. Please, can you
I'm
say
here.
something to the House as the chairman of this special subcommittee? Thank
you. Thank you, moderator, my Igbo secretary, Adaize Ayok. I want to thank you. I want to thank the speakers. I want to thank my president for the speech. I heard you, man. Yeah, you have been in the forefront of fighting pneumonia. You were once the chairman of this committee, and you did excellently. I want to thank the PE, the president-elect. I want to thank everybody and welcome everybody to this today's webinar. Pneumonia is a topic that you can never have enough of. It's a topic that is always topical and relevant, always in the mainstream of childhood mortality. When we talk of pneumonia, most of the time we are thinking of death alone, but pneumonia is doing a lot of damage to children that we don't even realize. So there is no need there's no gainsaying the fact that there is need for us to continue to discuss pneumonia, because the harm pneumonia is doing is beyond causing death. The mortality is something we cannot even imagine. Many children are left with lifetime disabilities that we may not even imagine or remember that it was due to pneumonia. So today's lecture is very relevant, considering the fact that there is need for us to sharpen our skills concerning pneumonia treatment and diagnosis. So we are going to start off. I will straight away introduce the speakers for today's webinar. The topic is childhood pneumonia, current perspective.
Please,
there is so much noise. Can you mute your loudspeakers?
Kindly mute your microphone. Ezrike, please mute your microphone.
Dr. Ezenwa, mute your phone.
Dr. Wilson, please go ahead.
Hello, can I start now? Or can I continue? Sorry. Hello? Yes. Okay. I hope I was being heard to the point of the title. I said the title is Childhood Pneumonia, Current Perspective on Diagnosis, Management and Prevention. The moderator, we already know, Dr. Adaize Ayuk. She's a professor and consultant pediatric pulmonologist, the University of Nigeria, Nsukka. Yes, the speaker for today are two of them. The first is Dr. Mohammed S. Abubakar. He is a consultant pediatrician, Department of Pediatrics, Cardiopulmonary Unit, ABU, Teaching Hospital, Kano State. While the second speaker is Dr. Adefuke Babatola, consultant pediatrician, Department of Pediatrics, Ekiti State University Teaching Hospital, Ekiti State. I have no doubt in my mind that these two speakers are going to do justice to this topic. I want all of us to relax and enjoy yourselves. Well, at the end of the first, I think, 45 minutes of discussion, there will be room for questions, and answers will be provided as much as we can. Thank you very much. If you have questions, note them. At the end of the presentation, there will be an opportunity for you to ask your questions. So the speakers, I think we are ready now. The first speaker is Mohammed Abubakar. Is it? The first speaker is Mohammed Abubakar. Adaise, sorry, let me hand over to the moderator at this point to take over the presentation. Adaise, are you with me? Hello. 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 Sorry, are you hearing me?
Yes.
Hear
Yes,
you.
we can hear you, sir.
If you can hear me, I say Adaise took over, you take over the presentation as the moderator.
Dr. Ayu, can you hear us? You need to unmute.
Is she with us?
I
Okay,
can still see her.
Sorry, who is the first speaker?
Yes, she is. Dr. Ayuka.
Is Ayuk with us?
Babatola is the first speaker, sir.
Okay, so Babatola can start. Share your slides and start. Babatola,
Yes, sir.
share your slides and start your presentation.
Yes, sir.
I hope Ayuk is still with us to take over as moderator. So start your presentation. Hello, Babatola.
Good afternoon. I hope I'm audible.
Yes.
You're audible. Go ahead, please.
All right. Good afternoon, my teachers, senior colleagues, and colleagues. I'll be starting this presentation titled Childhood Pneumonia Diagnosis and Management, Current Perspectives. Pneumonia simply means inflammation of the lung parenchyma caused by pathogenic microorganisms like viruses, bacteria, and fungi. And it often presents with fever, respiratory symptoms, and lung parenchyma involvement, which is often diagnosed through physical examination or presence of infiltrates on the chest radiograph. And we know that pneumonia is the largest infectious cause of death among children worldwide. It was still responsible for about 700,000 deaths of children under 5 in 2019. And we know that pneumonia affects children worldwide, but cases and deaths are more in the sub-Saharan Africa and South Asia, where there's limited access to health care. This slide shows the global burden of pneumonia in the past and in the recent. The world map on top shows death rate for pneumonia as at 1986, and we can see that there are many countries with high pneumonia death rates indicated by the dark blue colored areas, compared with this lower world map, which also shows death rate from pneumonia as at 2021. And we can see less countries with high pneumonia death rate, which shows indeed that there is a gradual reduction in pneumonia cases and deaths. However, pneumonia remains a disease of public health importance. Now coming to Nigeria, Nigeria remains one of the countries with high pneumonia death rate, with as many as 143,000 children under 5 dying from the condition annually. And this figure is far from the Nigeria's 2030 target
of having pneumonia death rate of 26,000 per year. We know that a lot has been done to get us to where we are by several bodies, the Pediatric Association of Nigeria inclusive. However, if we are to achieve this 2030 target, we need to do more. Pneumonia is primarily transmitted via the inhalational route, but can also be transmitted via the hematogenous route, particularly in the newborns, the young infants, and the severely immunocompromised. And we know that pneumonia can be classified using various parameters, which include source of infection into community-acquired pneumonia, which shall be our focus this afternoon, and hospital-acquired pneumonia, also known as nosocomial pneumonia. Community-acquired pneumonia is pneumonia in a previously healthy child who acquired the infection from the community, or a child who develops pneumonia within 48 hours of admission. Pneumonia can also be classified based on the organism responsible for the infection into viral, bacterial, or fungal. And we know that pneumonia can also be classified based on the area of the lung involved into lobar pneumonia, when a whole lobe or a segment of a lobe is affected. And this often shows on chest radiograph as a smooth, dense opacity. Then bronchopneumonia, which is seen on chest radiograph as patchy opacities in the lung field, particularly around the bronchi and the bronchioles. And interstitial pneumonia, when the parting between the alveoli is involved. Then pneumonia can be classified based on duration into acute pneumonia and chronic pneumonia. Acute pneumonia, when signs and symptoms of pneumonia have been on for less than 2 weeks, and chronic pneumonia, when the signs and symptoms of pneumonia have been on for more than 2 weeks. And mycoplasma agents and fungal agents are commonly responsible for chronic pneumonia. Then based on severity, into pneumonia, which is non-severe and severe pneumonia. I'll discuss this in details later. And there are some more recent subtype or classification of pneumonia, which include healthcare-associated pneumonia. This pneumonia is found in individuals with frequent exposure to the health facility, for example, those on chronic dialysis or those residing in nursing home. What is peculiar to this type of pneumonia is that it's often caused by resistant microorganisms, such as methicillin-resistant Staph aureus. Then aspiration pneumonia, which is due to inhalation of foreign materials into the lungs. And this is commonly seen in children with anatomic facial defect like cleft palate, or children who are recurrently being force-fed. Then ventilator-associated pneumonia is actually a subset of hospital-acquired pneumonia, and it occurs in individuals with prolonged mechanical ventilator use. The immunocompromised host pneumonia is seen in individuals with weakened immune system, such as those with HIV infection, those on prolonged use of steroid, or those undergoing chemotherapy or organ transplant. And the common respiratory pathogens and the opportunistic organisms are commonly implicated. So now coming down to etiology of pneumonia. A recent study by Mollendorf et al. On the etiology of childhood pneumonia in low and middle income countries in the area of vaccination reported that viral Cs are the leading cause of pneumonia in that particular study, and it accounted for about 60% of the cases. Respiratory syncytial virus, human metapneumovirus were the leading viral agents. Bacterial etiology accounted for about 30%. Streptococcus pneumoniae, Haemophilus influenzae, and Staphylococcus aureus were the leading bacterial agents. Tuberculosis accounted for about 6% of pneumonia in that case, in that review. And the study also noted that mixed bacterial and viral infection were common, and that severe cases of pneumonia are often caused by bacterial agents. The study also noted that pathogen distribution varies by age, with the younger infants having more of a viral pneumonia. The malnourished and the HIV-infected children had more of a bacterial pneumonia in that study. And the study also observed regional variation in the etiology of pneumonia, with a higher bacterial pneumonia rate in the World Health Organization African region office countries, while the Southeast Asian region office countries and the Western Pacific region office countries had more of a viral pneumonia. Now coming down to Nigeria, there's actually few studies on etiology of community-acquired pneumonia among Nigerian study, particularly in the last 15 years. And only one, even after the introduction of pneumococcal conjugate vaccine into the NPI schedule in 2014, and that is the Bello et al. Study, that reported Klebsiella to be the leading bacterial agent in that particular study, which is at variance with earlier reports of Streptococcus pneumoniae, Haemophilus influenza type B, and Staphylococcus aureus being the leading bacterial agent. This calls for more study on the etiology of community-acquired pneumonia among Nigerian children, the contribution of viral and atypical pneumonia to community-acquired pneumonia among Nigerian children. This is because the inclusion of pneumococcal conjugate vaccine into the NPI schedule might have altered the etiology of CAP among Nigerian children. And the findings from this study may warrant a review of our current treatment guideline. Now coming down to clinical symptoms of pneumonia, we know that pneumonia can present with a wide array of symptoms, but the main symptoms, particularly in older children, are cough, difficulty with breathing, fast breathing, fever, and chest pain. For the newborn and the young infant, they often present with non-specific symptoms like fever, reduced activity, poor feeding, and vomiting, which implies that we need to have a high index of suspicion to make diagnosis of pneumonia in that age group. So now coming to the World Health Classification of pneumonia based on severity into non-severe pneumonia, that is pneumonia, and severe pneumonia. The features of non-severe pneumonia include fever, cough, fast breathing, difficulty with breathing, and mild chest wall indrawing. While for severe pneumonia, features of non-severe pneumonia plus at least one of the following World Health Organization danger signs, which include central cyanosis, severe respiratory distress, grunting, inability to breastfeed or drink, lethargy, unconsciousness, or convulsion. A type with complications of pneumonia or comorbidity is also classified as having severe pneumonia. The clinical signs of pneumonia is often non-specific. It includes fever, respiratory distress, tachypnea, and cyanosis. Presence of complications, for example, that of heart failure, tachycardia, tender hepatomegaly may also be present. Chest examination may be normal, particularly with non-severe pneumonia, that is pneumonia, and bronchopneumonia. There may be reduced chest movement, dull percussion notes, increased vocal fremitus, increased vocal resonance with lobar pneumonia. The breath sound may be decreased, particularly with lobar pneumonia. It may be absent if complications like pleural effusion are setting. Then there's also bronchial breath sound in lobar pneumonia. Cavitation can occur in both bronchopneumonia and lobar pneumonia. We know that just like other clinical conditions, diagnosis of pneumonia starts from the history and the physical examination. And this is actually the trend of focus to be able to make community diagnosis of pneumonia and institute community-based care, or is promptly institute pre-referral treatment as may be appropriate. So investigations are just to support or to confirm one's diagnosis. And the investigations relevant in pneumonia can be broadly grouped into three: supportive investigations, radiological investigations, and microbiological investigations. We know that the extent of investigation to be conducted on a patient depends on the perceived severity of the infection, what is available in the facility, and affordability. Now coming to radiological investigation, plain radiograph remains the reference standard and most commonly used imaging technique for confirming diagnosis of pneumonia. Can also help with anatomical classification of pneumonia and can also help to rule out some common differentials like pleural effusion. Lung ultrasound is gaining relevance in the diagnosis of pneumonia now. This is because it can be done by the bedside, and it does not use the ionizing radiation, so can be repeated as appropriate. And studies too have reported diagnostic accuracy that is comparable to or even superior to that of a chest radiograph. This slide shows some common lung ultrasound imaging findings related to pneumonia. The topmost one shows a presence of a pleural line, which is an echogenic line with A lines. This is what is seen in a normally LD aerated lung. This middle one shows the white arrows pointing to the B lines, which is usually vertical to the echogenic pleural line. Presence of more than 3 B lines is said to be suggestive of pneumonia. And this lower one shows the white arrow pointing to ear program surrounded by hypoechoic area, which suggests pleural effusion. Presence of liver-like appearance on lung ultrasound also suggests pneumonia. And despite the usefulness of lung ultrasound in making diagnosis of pneumonia, its use in our own environment is still limited because of factors such as that the interpretation of the findings is often dependent on the experience of the somnologist. Also, the fact that many of the healthcare workers are not skilled in the use of using lung ultrasound for making diagnosis of pneumonia. Also, the ability of ultrasound. Chest CTs are not making is believed to be the most but it's rarely used in clinical practice, but it uses, we know it's for clinical practice because it is, but we know that the yield for blood culture is quite low. Other samples that can be used include pleural fluid, nasopharyngeal, and sputum. Serology could be done for organisms like Mycoplasma and Chlamydia species. There are newer molecular techniques like the multiplex polymerase chain reaction, which can be used to diagnose multiple pathogens using a single test. It can also be used to know the resistant gene, but these facilities are not available in many of our health institutions, probably because of its high cost. Multilocal sequence typing tool can be done to isolate some bacterial agents. Then loop-mediated isothermal amplification method too can be used to detect organisms like Streptococcus pneumoniae, pertussis, and Ruby streptococcus. This facility also is not available in many of our health institutions, and the few centers where it is available is deployed for use in making diagnosis of tuberculosis. We all know the challenge with making diagnosis of viral units in our environment. However, rapid antigen detection tests can also be done to identify some viral antigens. But as I said earlier, many of these facilities are not available in our centers. Supportive care is quite critical in the management of oxidation, very important. C-reactive protein and procalcitonin are often elevated in pneumonia. Then ancillary investigations like full blood counts will also be done. It may show us anemia, which is a common complication of pneumonia. Then serum electrolyte, urea and creatinine should also be done. Metabolic acidosis is a common complication of pneumonia. Then random blood sugar should be done for any patient that is sick enough to require admission, particularly those of them with inability to eat or drink, because hypoglycemia will coexist and this should be promptly addressed. HIV status should be done but admitted. This is because of the important role of pneumocystis jirovecii pneumonia, particularly in infants with HIV infection, which can influence our management. Pneumonia can be treated on outpatient and inpatient basis. So what are some of the indications in a child whose age is less than 2 months? Presence of severe pneumonia, pneumonia in a child with severe malnutrition, pneumonia in a child who is HIV infected or severely immunocompromised. Supportive investigation, I said earlier, is quite critical. So we need to give oxygen to any child with oxygen saturation of lesser than 90% or presence of severe respiratory distress like grunting or severe head nodding. Nutritional support is quite important. Small, frequent oral feed is what is recommended. Unless there is a significant tachypnea that is sufficient enough to pose a risk of aspiration, then fever could be discomforting. So we can make use of appropriate antipyretics. We should also monitor our patient closely. Monitoring of vital signs to include oxygen saturation every 3 hours, and the doctor should review the patient at least twice per day, and we should identify complication on time and manage promptly. So coming down to specific treatment, which is the use of viral pneumonia and bacterial resistant pattern of that locality, field street, HIV status, nutritional status, and vaccination status. For any patient that we are suspecting pertussis pneumonia, mycoplasma or chlamydia pneumonia, we need to add macrolide to the treatment. And corticosteroid is an important adjunct in the treatment of pneumocystis jirovecii pneumonia. This slide shows our current treatment for them that are amoxicillin is the recommended first line for outpatient. For inpatient, intravenous amoxicillin plus gentamicin. For HIV infected, for inpatient treatment plan, in addition to the intravenous amoxicillin and gentamicin, we need to add high dose cold retromycin. So when can we discharge our patients? When resolution of fever, respiratory distress, fast breathing for at least 24 hours, when the caregiver is comfortable with discharge and able to administer oral treatment at home. And at that time, too, we need to plan our follow-up, which should be not more than 48 hours after our discharge to review our patients. A study from Osogbo on children admitted for pneumonia reported that congestive heart failure to be the leading complications of pneumonia in that pathway. Other complications include, this slide shows some common differential diagnosis of pneumonia, particularly in the young infants. Both of them can present with cough, both can present with fever, both can present with respiratory distress and fast breathing. However, for bronchiolitis, one may get a history of contact with an adult or older children with features of upper respiratory tract infection. And if upper respiratory tract infection may precede the worsening cough or the worsening difficulty with breathing in children with bronchiolitis. Then asthma is also a differential. Both can present with cough. However, in asthma, fever is not often significant. And also, for asthma, there's recurrence of cough, recurrence of the difficulty in breathing, and there may also be atopy in the family or in the particular child, and there's often dramatic response to use of bronchodilator with asthma. Then croup is another close differential. However, in croup, there is often inspiratory stridor, and the cough in croup is backy. Then foreign body too is another differential. However, with foreign body, the cough is often sudden in nature. One may get a hitch of the child playing with toy part or eating groundnuts or not before the onset of the sudden cough and the choking. And there may be stridor or localized wheezing, depending on where the foreign body is lodged. So here, hence, this part of the presentation, I want to especially appreciate the leadership of Pediatric Association of Nigeria and the Nigerian Thoracic Society, the Pediatric Assembly, for giving me this opportunity. And I want to say thank you to everyone for listening. These are my references. Over.
Dr. Ayuk, are you there? You can take over. Thank you.
Yes, the second speaker is supposed to take over, but I had said if he's having issues with his network, the first speaker can continue. The slides are joined.
Good afternoon, ma'am.
All right, Mohammed.
Good afternoon, ma'am. She can just continue with the slides over there while I take the presentation from there.
Okay, Mazu, so just keep showing his own. He will talk from a phone.
His slide is up now.
Yes. All right. Okay, thank you.
Good afternoon, everyone. Good afternoon, my teachers and our colleagues. I am Muhammad Shakur Abubakar. I will be taking the second part of the presentation. It is very important to know that when a child dies from pneumonia, it is not just a tragedy, but it is a failure of prevention. Based on that, we'll be discussing how to prevent this deadly disease among children, with first looking at the risk factors. Then by proper understanding of these risk factors, we'll be able to look at how to prevent this disease and also briefly discuss the vaccines. So looking at the risk factors, we'll be looking at them in three categories: those related to the child, those related to the environment where the child resides, and those due to the socioeconomic conditions that the child faces. Those related to the child basically affect the immune system of the child, either directly or indirectly. Among them are congenital or acquired immunodeficiency conditions. And these are a bit self-explanatory. And also malnutrition in a way causes reduced immunity in the child. And especially it is associated with reduced immune function, especially those of the T cell and also some of the antibodies. Congenital heart disease is another condition that has been linked with high burden of pneumonia among children, especially recurrent pneumonia. The explanations offered include increased pulmonary blood flow from those associated with shunt lesions. This creates stasis in the lungs, which promotes infection. Also, the cyanotic congenital heart disease is mostly associated with right to left shunting. Therefore, the microorganisms that are bloodborne bypasses the pulmonary alveolar macrophages, thereby leading to proliferation of these organisms and causing infection. Other conditions that may be associated with congenital heart diseases, like those with DiGeorge syndrome, tend to have thymic aplasia or hypoplasia, and this is associated with T-cell immune deficiency, which will also predispose the children to infection. Another condition includes those that are associated with subsplenic abnormalities, either asplenia or hyposplenism, in those with situs ambiguous and other situs abnormalities. Also, asthma has been known to be associated with increased mucus secretion, and also the chronic inflammatory condition contribute to abnormal epithelial surface, which promotes easy movement of the of the microorganisms into the respiratory system and causing infection in those group of children. Sickle cell disease is also known to be associated with defective alternate immune system because of the hyposplenism or hyposplenism that they are usually faced with. And most of these organisms that are prevalent among them are the encapsulated organisms, which are mainly the ones that causes pneumonia, like strep pneumonia and other ones earlier mentioned. Neuromuscular disorders could be associated with those with cerebral palsy, for example, or those with those also, this could lead to in some instances, those with depressed consciousness, and this usually causes pneumonia because of the decrease in proper respiratory function and respiratory exposure. Bronchopulmonary dysplasia also is a condition that is mainly seen in premature infants, and it's associated with increased prevalence of pneumonia. Cystic fibrosis also because of the increased mucus secretion. Also, those children with pre-existing illnesses, like those with symptomatic HIV infection, those with measles. HIV basically we know is associated with immune deficiency, while measles is associated with increased susceptibility is associated with increased immune deficiency because it affects the epithelial surfaces basically, and also is known to be associated with deficiency of vitamin A. This all predisposes the children to pneumonia. Gastrointestinal disorders like gastroesophageal reflux and tracheoesophageal reflux contribute to either chemical aspiration or microorganism aspiration from the GI, leading to pneumonia in those group of children. Age has also been found to be a very important factor in pneumonia among children. Infants generally are at higher risk of pneumonia because most of the antibody or their immune system are acquired antibody from their mothers, which tend to wane by the age of 6 months. So they have defective adaptive immunity, therefore predisposing them to high rate of infection. Also, immune system of premature infants. The next slide, please. The immune system of premature infants have been found to be also less adaptive and also not well developed compared to the term infant. The reason being that most of those antibodies that are transferred from mothers, the transfer occurred during the late term of pregnancy, usually after 28 weeks and above. And most of them actually after 34 weeks. So those that are born before this time tend to have less amount of antibody and at higher risk of infection. Low birth weight also is another concept that is linked to fetal malnutrition, which is almost the same thing with malnutrition as seen in other children. So they also have the same problem with their immunity. Lack of immunization is perhaps one of the most important factors that is responsible for pneumonia in those children, especially the young infant. So now, since we have vaccines that are targeted against most of the organisms that are responsible for pneumonia in those age groups. Looking at the environmental factors, most of the factors from the environment are consequences of activities of adults that are living with the children, like indoor air pollution that is caused by cooking and eating with biomass fuels, such as firewood, and also living in crowded homes. This has been shown to promote transfer of organisms from individual to the other, therefore promoting the spread of pneumonia. Passive smoking has been found to be a very important risk factor for pneumonia in children. Adults who smoke usually believe it doesn't affect children, so it's a bit difficult to get even parents that smoke not to smoke around their children. Among the environmental factors also include the seasonalities. This is more important in other climates than ours because peaks of certain organisms that cause pneumonia have been found to be associated with certain period of the year. Also, temperature, cold temperature, for example, weakens respiratory defense mechanisms, while humidity, when it is very low, enhances viral stability, and these have been shown to increase infection during those periods of time. Air pollution and also exposure to smoke. This has been an issue for a while, and especially in cities and around industrial areas. This increases smoke, soot, and other pollutants in the environment, and these have been known to weaken the immune system, especially the epithelial surface of the respiratory tract, and exposes these children to higher incidence of pneumonia. Absence of sunlight and vitamin D also is another risk factor, because vitamin D has been found to be associated with better immune system. And also rickets on its own reduces respiratory effort and weakening the respiratory muscles, thereby promoting pneumonia among these group of people. Other human behaviors like crowded living condition and poor sanitation have also been linked with pneumonia. The socioeconomic status of the child is also very important, because in a community, in a poor community, they have poor access to health facilities. And even when the child has pneumonia, treatment is often inadequate or delayed. And this leads to mortality and more complications. Also, low level of education by the mothers means they are less likely to assess preventive behaviors, and also they are also less likely to identify severity of diseases early. And when they do, they are less likely to seek appropriate care because they tend to patronize either quacks or traditional healers. Family size also has been found to be a factor. This reduces the purchasing power of the family and also the ability to foot their medical bills. It has been found that in resource-limited countries, hospitalization needs for pneumonia is much more higher. It's about 50 to 80%. While case fatality in that environment also has been found to be almost up to 15 times more than it is reported in developed countries. It's also very important to know that these three factors I've mentioned, the child, the environment, and the socioeconomic status, have an interplay between them. For example, a child that is born to a mother that is not educated, the mother is more likely to be poor. They are more likely to live in an environment of low socioeconomic status. Therefore, this child is faced with multiple problems right from birth. Again, these children are more likely to live in overcrowded areas. They are less likely to be vaccinated, and the cycles continue that way. Therefore, it's increasing their risk of exposure to pneumonia and their risk of deaths when they are infected by any of the organisms that causes pneumonia. Premature infants also, for example, are more likely to be hospitalized. They are more likely to need intensive care where it is available, and they are more likely to be intubated. And all this increases risk of hospital-acquired infection among other things. So we will now be talking about the preventive strategies. We'll be looking at the preventive strategies through the 3 levels of prevention, 5 levels of prevention, which include the general health promotion, specific protection, prompt diagnosis and treatment, limitation of disability, and rehabilitation. Under the level 1, very important is adequate nutrition. This supports the immune function of the child. Also, exclusive breastfeeding is part of this. It reduces risk of infection because the breast milk has been found to contain some items, some antibodies rather, contain antibodies which also help in preventing infection among the children. Good hygiene practices are also very important, which include hand washing, safe food handling, and clean environment. This help break the chain of transmission from one individual to another. Also, reducing indoor air pollution is very important. This will include discouraging elders or caregivers from smoking among the children, and also using alternative source of fuel instead of the biomass fuels. Generally, educating the community on those risk factors and how to prevent them is also very important. Level 2 is specific protection. This is where the vaccine and vaccinations come in. So vaccination against pneumococcal and Haemophilus type B influenza is very important. Also TB and measles all fall in under this group, and vaccination against them significantly reduce the severity and prevalence of pneumonia among children. Also seasonal vaccination where applicable in places against those viruses, influenza virus and respiratory syncytial virus is also very important. Also use of preventive antibiotic in certain population like the isoniazid preventive therapy in those with HIV/AIDS, the use of the cotrimoxazole chemotherapy in this same group of children against pneumocystis jirovecii. All these are important part of specific protection against pneumonia. Level 3 is early identification. This is basically through identifying the symptoms that causes pneumonia, like fever, cough, fast breathing. Any child that is suspected to have pneumonia should be taken to hospital early, and the doctor should be able to identify these symptoms early and also institute timely medication, as earlier highlighted in the earlier presentation. Appropriate antibiotic use is also very important because we know some organisms could be resistant to certain group of organisms, and certain background condition, like earlier highlighted, will warrant the use of certain group of antibiotics in addition to the conventional antibiotics we use. Supportive therapy is also very important. Oxygen, for example, has been found to increase survival among those with severe pneumonia, especially when the oxygen saturation is less than 90%, or in those with complication when it is less than 94%. So use of oxygen has been found to increase survival very well. And it is a marker that could be used to see those children that are at high risk of mortality. If by the time you stop oxygen, the child desaturates within 10 minutes, it indicates that that child is at high risk of mortality, and close monitoring is required in this group of children. Level 4 is preventing the complications. That's early treatment of hypoxia, sepsis, and empyema. Also, integrated care is very important, like addressing other comorbid conditions like malnutrition and heart disease. Also, home-based care is important during discharge. Under level 5, the goal is to restore function and quality of life of the child. Therefore, pulmonary rehabilitation comes in this stage. Part of the local ways of pulmonary rehabilitation will include breathing exercises, which the mothers can be taught how to help the children with it. And also, sometimes incentive spirometry may be important, which we can also improvise using a balloon when the spirometer or peak flow meter is not readily available. Also, counseling for post-hospitalization recovery is very important. Long-term monitoring and follow-ups are very important, especially in those with background comorbid conditions like those with congenital heart diseases and so on. I will briefly discuss the role of vaccination in prevention of pneumonia. Currently, the key vaccines that I use include our pneumococcal vaccine, the Haemophilus type B, influenza type B vaccine, the measles vaccine. The influenza vaccine is not readily available in the country. It's not part of our national immunization program. However, the others, including the BCG, are available. And the use of these vaccines have been shown to have reduced significantly morbidity and mortality from pneumonia. This is mainly through the efforts of PAN, advocating for children rights and protection against this group of organisms. Pneumococcal vaccine are available in different serotypes. However, with the current campaign and also the involvement of WHO, About over 150 countries have included PCVs in their immunization program, and that has been a very important milestone that has helped in reducing the prevalence and mortality of pneumonia worldwide. The WHO recommends 3-dose schedule for infants, which is what we also practice here in Nigeria. Current trends in pneumonia vaccination include development of higher serotypes like PCV20 for broader coverage. This is not yet available in our environment, but it is currently available in some countries. Routine immunization, also expanding those routine immunization to involve low-income countries, has been one of the achievements. Also, the emphasis recently has been on cost effectiveness and herd immunity. Herd immunity is said to have been achieved if up to at least 95% of the population of the children that are at risk have been vaccinated. This helps in breaking the chain of infection. It's just like having, for every one child that has pneumonia, you have at least 9 other children surrounding that child without pneumonia. This helps in breaking the chain of transmission. Also, ongoing surveillance for serotype shift. Because of the development of these vaccine serotypes, the serotypes that either before now were found not to be of clinical relevance have now emerged as more important, and thus, therefore, surveillance for this serotype shift is very important because it could be a threat later if nothing is done. There has been challenges in implementation of this vaccine coverage. Part of it is vaccine hesitancy. The main problem with hesitancy is basically when parents or individuals refuse or delay in taking their vaccination, even when it is available. And many reasons have been proffered as possible reasons why people do this. It could be mostly it is due to ignorance, also lack of understanding of the severity of the disease. Some think the disease is milder compared to the side effect that will arise from vaccine. And underlying issues among these include a lack of trust in the government and the healthcare providers. So therefore, to achieve or to reduce hesitancy and also increase vaccine coverage, there is need for proper sensitization of the community, and also the government should regular sensitization by also health workers during each contact with caregivers and their children. Cold chain and logistical issues are also very important, especially in communities where power supply has been an issue. Some of these vaccines need cold chain, and if that cold chain is broken along the route of transmission, they may become invalid, and even when they are administered, we may not have the effects that were expected to have from them. Funding constraint has always been an issue in low resource settings because it's mostly issue of priority in addition of lack of available resources, inadequate availability of resources. Therefore, most of this funding are from foreign donors and also developed countries. So the recent decision by the United States, for example, to withdraw funding with regard to some of those activities are threats to achieving this wide coverage of vaccination worldwide. As a form of conclusion, it's very important to remember that pneumonia remains an important cause of morbidity and mortality in children, particularly in developing countries like Nigeria. It is largely preventable with non-intervention, which has proven over time. Therefore, pediatricians should identify these risk factors, encourage breastfeeding and hygiene. Vaccination remains a cornerstone of prevention, so we should emphasize vaccination at each stage. Also, we should also remember that prevention requires multi-level strategies from health promotion to rehabilitation. While we'll emphasize the importance of vaccination, we should also remember these other levels of prevention. Vaccination, early treatment, and rehabilitation are critical pillars in the management and prevention of pneumonia. Thank you, everyone, for your time. I want to thank
So thank you very much. Yes, Professor Osaro Dr. Sargiabon would take on the question and answer session and also be able to handle whatever else. Professor.
Hello. Hello.
Yes, we can hear you, sir.
Well, at this point, let me thank the speakers for a job well done, for a very lucid presentation on both sides. Well, what I will say at this point is that if you have any question, you will unmute yourself and ask your question. Unmute yourself and ask your question so that, let's start with the first speaker, Babatola. You will note your questions and you answer them at the end of the, well, I think the questions can be for any of the two. You ask your questions, whosoever is concerned will note the question and will answer it. So ask any question. The two speakers are ready to take the questions. The speakers, are we ready? Mohammed and Babatola, we are ready for the questions.
Yes, sir.
Okay. So anybody can ask any question. We'll see who is in charge of who will handle the question or who it goes to. So anybody who has, is there anybody that has a question to ask or comments or comments? Hello?
Question, sir.
Yes. Go ahead, introduce yourself and ask your question.
Okay, I'm Oronsaye Egwavon from UBTH. I want to sincerely appreciate the presenters for a very lucid presentation. I don't know if I missed it. I need clarifications. But one of the speakers had said during management of pneumonia, particularly when you suspect PJP, that one of the things we give as adjuncts is steroids. So my question is it statutory? In other words, is it a strong recommendation or is it just something you do, you have to individualize your patients? So if you suspect PJP, I would assume that that patient will be immunocompromised and giving steroids probably is going to further worsen the immunity. Okay, so if we're going to give, then the other question now, the follow-up question will be for how long is it going to be given, and perhaps what dose you want to give. Okay, thank you very much.
Hello.
Unmute yourself and ask your question.
Good afternoon, everyone. So my name is Professor Sado. Hello.
Okay.
Am I being heard?
Hello. Yeah.
Am I being heard?
Yeah.
Good afternoon, everyone. This is Professor Sado from Benin. I want to thank the presenters for their lucid presentation. Unfortunately, for network reasons, I missed some of it. But I just want to say, make a correction, that Haemophilus influenza type B is actually in the Nigerian program. It is part of the pentavalent vaccine. So the pentavalent vaccine contains diphtheria, pertussis, tetanus, Haemophilus influenza type B, and hepatitis. My question is, how much of a problem is respiratory syncytial virus in the etiology of pneumonia in Nigeria? I'd like to know because there's a vaccine for respiratory syncytial virus, and it's based on the burden of the disease. Partially, that's one of the reasons that you consider for advocating for that particular vaccine into the national program. So I'd like to know how much of a problem RSV is for us as a country. Thank you.
Thank you, ma'am. Thank you, ma'am. Professor Mrs. Sado. Any other question?
There are questions in the chat
Yes,
box,
sir.
sir. There are some questions in the chat box.
Yeah, somebody already.
Those questions in the chat box. Professor Ayo. Professor Ayo. Hello. Hello.
Hello.
Hello.
We can hear you, sir.
Yes. If there are more questions, if there are none, then we can read some of
I
those.
have. Oh no, I'm raising my hand. Good
Yes, go
afternoon.
ahead. Introduce
Yes,
yourself.
good afternoon. Yes, our dear president of PAN, the ESCO, the Pulmonology group, very powerful group. Thank you for bringing to the fore this topic. Everybody thinks they know about pneumonia, but I'm not sure all of us know enough about pneumonia. So today has been a good day. And more importantly, on the aspect of antimicrobial stewardship, I'm happy that at least it's been pronounced here that the first line treatment for CAP, for community-acquired pneumonia, is amoxicillin. It is not cephalosporin. It is not carbapenem, meropenem. It is none of those. I'm happy that all that has come up. Of course, when you have added problems, immunodeficiency, and some of the other problems, then you can individualize. Because many centers are using cephalosporins as their first line. When we start using all these ceftriaxone as first line, what will happen when we have now accumulated lots of resistance? Because that's what is happening. We're overusing the cephalosporins. We're overusing the carbapenems when they are not supposed to be used. That is why the bus stop for us is meropenem most of the time. Let us spare these higher level antibiotics and use pneumonia is mainly organisms that are amenable to first line antibiotics. So that's what I wanted to bring out here. Thank you very much. And then the WHO says, even if you have bronchiolitis clinically and all that, sometimes it's difficult for you to really differentiate that you're dealing with viral or bacterial pneumonia. It's still safer in a low middle income setting to use antibiotics. But if we use low level antibiotics, there wouldn't really be so much problem with that. I just wanted to contribute all those. And then to know that for immunization, elsewhere, they now have more serotypes in their PCV. I don't know when that will get to us, so that we'll be able to cover the serotypes that are not in our PCV 10 that we're using in the. Thank you very much, the Pulmonology group.
Thank you. Thank you. Any other question? Or we have enough? Then we can read some from the chat box. Hello?
Dr. Aliu Suleiman has
If you don't, we can take those in the chat, some of those in the chat box. Can we? Or do we still have other questions, other hands up?
Dr. Aliu, unmute and ask a question.
Okay.
Dr. Suleiman.
If not, I want to take this. I don't know if this is really a question. You were particular. I hope Mohammed and Babatola, you are listening. You were particular about adding erythromycin to amoxicillin and gentamicin in the treatment of pneumonia in sickle cell disease patients. Why not just macrolides? Why not just macrolides? Consider the side effect of erythromycin, hives, and the fact that why is erythromycin preferred to azithromycin? That's one question here. I hope that is noted. Are we taking notes?
Yes, sir.
Thank you for your presentation. I just want to ask about long-term complications of pneumonia. That's a question. What is the role of zinc in the management of bronchopneumonia? That's one question. Can vitamin A also be used as adjunct in the treatment of CAP? I hope I'm not too fast. Somebody said, thank you, Dr. Shaka, for the beautiful presentation. It was very lucid, I must say. Well, that's no question. Thank you for the presentation. Please, how can we clinically differentiate bronchopneumonia from bronchiolitis? Well, this is not a question. He said, can the slide be shared? If yes, kindly assist me. The person provided an email. Can you, he said, how do we differentiate between pneumonia and acute chest syndrome? He said ACS. I assume that is acute chest syndrome in sickle cell anemic patients. As part of complications mentioned, anemia was mentioned. What is the likely cause of anemia in acute pneumonia? The chronic one can be worked out, but the acute pneumonia, what is the cause of anemia? He said a big thank you, both speakers, for the brilliant presentations. The incidence of CAP seems to be down following inclusion of PCV into the routine schedule. I believe the time is right to know the true burden post-PCV introduction. If there is no effort in this direction at the moment, where can we start from? Many thanks. Well, those are some of the questions. I think they are on and on. I think we have had enough. Somebody said, good afternoon all. Very good work by the presenter. The little I can grasp as it is really interminated by disturbing the network was good or something. Thank you, Dr. Cletus. Abi? Can someone unmute me, please? No, that's not a question. Thank you to the speaker for beautiful presentation. I think those are basically the questions. If there are no other questions, I will now tell the speakers to go ahead and address the questions as it concerns you. Read out your question. Let's start with Babatola. Read out your question as you're answering them. Take them one by one so you can start.
Thank you very much, sir. I want to start.
Professor Ayuk is also around, Abi. Ayuk.
But she doesn't seem to be around.
That's what I'm bothered.
Because we have less than 20 minutes. So.
Yes. So I just think that we should answer the questions as it concerns you. Then we are not enough. Thank you.
Yes, sir. Thank you very much, sir. And thank you for the questions. I'll start with the use of corticosteroid as an adjunct in the treatment of pneumocystis jirovecii pneumonia. This is particularly for severe PJP. And this is because of the severe inflammatory reaction that tends to occur. And the dose is prednisolone, 1 milligram per kg, and should be given for about 5 days. As I said, it's mainly for severe PJP. Then how much is the contribution of respiratory syncytial virus to the contribution of CAP in Nigeria? I cannot really say. I said earlier that there are few published studies on the etiology of CAP in the last 15 years. And I think this is what we should take on now. We should look at the contribution of viruses to CAB in Nigeria. Then the role of zinc in the management of pneumonia. Some studies have reported that it could be beneficial. However, it is said that it is more of preventive, not as a treatment during the acute management of pneumonia. Then can vitamin A be used in the management of CAP? This is when the pneumonia is following measles infection. If it is not following measles infection, it is not recommended. Then how can we clinically differentiate between bronchiolitis and pneumonia? I said earlier that it can be quite difficult. However, for bronchiolitis, we know that features of upper respiratory tract infection often precede the worsening of the cough and the respiratory distress, and fever may not be prominent in the bronchiolitis. And I said that one may get a history of the child having contact with other children or adults with the upper respiratory tract infection. Then both of them can have wheeze, but we know that wheeze is more with bronchiolitis. And pneumonia, a child with pneumonia often appears very sick compared to that of bronchiolitis. Then how do we differentiate between acute chest syndrome and pneumonia? We know that often with acute chest syndrome, there's even an inflammatory component, an infectious component. So it can be quite difficult to differentiate between both. However, a chest radiograph should may be able to help us and with some other clinical symptoms. We know that both of them will present with cough, but with both of them, there could be respiratory, there's usually dyspnea. But as I said, both of them often even occur together in practice. What is the likely cause of anemia? We know that in this part of the world, many of our children even have a borderline anemia before the infection setting. This may be the likely reason why they found anemia to be one of the leading complications in that particular study. I said that the study was conducted at Osogbo, so maybe many of the children in that particular study already had a borderline anemia. So these are the questions on my own side. Thank you.
Dr. Mohammed, go ahead, please.
Thank you, ma'am. Thank you, Dr. Wawatola, for responding to most of the questions. If I may add, for acute chest syndrome, for example, the differentiating acute chest syndrome from community-acquired pneumonia, like she rightly mentioned, the first presenter rightly mentioned, is most often very difficult to differentiate the two. But very key is usually acute chest syndrome only occurs in those with sickle cell disease. Even the chest X-ray may not help because it may just be an infiltrate or sometimes lobar consolidation. Occasionally, they may have other complications like effusion. So, I believe that's why the consensus in the management of acute chest syndrome include use of antibiotics, and it is assumed that there is usually some level of infection, even though the pathophysiology, apart from infection, there are other possibilities like infection and other pathophysiological mechanisms. So basically what we do is we treat both, and if need be, we had other treatment options. Also, with regard to the issue of anemia in acute pneumonia, in addition to the explanation the first presenter gave, which is very, very important and could be a contributing factor. Also, looking at the pathophysiology of pneumonia, the red hepatization stage is believed to be seedling of the lungs by the red cells. Okay, so this will lead to destruction of some of the red cells, and this can be a contributor to the anemia. And also, staph pneumonia in particular has been shown to be associated with pneumonia in children. trying to go through the questions that have not been answered yet. Okay.
Somebody asked if chest X-ray is necessary for all pneumonia.
Okay, no, it is not. And I think even this the presenter mentioned it, that the diagnosis of pneumonia is clinical. Investigations are usually either to confirm, if need be, or for identifying complications, especially chest X-ray. That's the most important reasons why chest X-rays are asked for, either to identify complications, which sometimes clinically may be a bit difficult to identify in children when they are not very florid. The chest examination may not be that easy to conclude if there is pleural effusion, minimal effusion, for example, pneumothorax, minimal one, and the rest. So that's where chest X-ray helps. And also in those with suspected congenital heart diseases, the chest X-ray will also help in this aspect by studying the cardiac seal and other things. This could be one of the reasons why the child may need an echocardiogram subsequently for further evaluation. Okay. During the presentation, I don't know whether it was a slip of tongue, but what I meant to say was all the antigens I mentioned there, the organisms I mentioned there, we have vaccine antigen against them, apart from the respiratory syncytial virus, as part of the national immunization program. Others like measles, tuberculosis, Haemophilus influenza type B, streptococcus pneumonia are all part of the antigens that are given for prevention for our vaccination program. I don't know if there is any other question that we have left out. So,
I'm not sure if this question on macrolides have been addressed. The one saying why adding erythromycin to amoxicillin. Yeah, the first one.
Okay, thank you.
Emphasizing, yes, erythromycin instead of just simply saying macrolides, or why are you not using erythromycin, knowing the side effect of erythromycin? Also, what's the explanation?
Okay. If I get the question very well, why add macrolide in management of pneumonia in sickle cell disease?
Why were you specific about erythromycin and not just simply saying add macrolides, but you said add erythromycin? And the person is now saying, considering the fact that erythromycin has some side effects, is there any reason why you want to prefer that to azithromycin? That's the question.
Thank you
Were
very
you
much.
specific about? Yes.
I was the one that said that. I simply stated what is in the current guideline. However, we know that though children, one of the adverse effects of erythromycin could be abdominal pain, but it's often not serious enough to stop the use of the macrolide if there is a need for it. So macrolide, erythromycin as the recommended first-line addition to the IV amoxicillin and the gentamicin. But alternative is azithromycin or clarithromycin. Thank you.
Well, just to say from the standpoint of antimicrobial stewardship, erythromycin is in the access group of antibiotics, and I think that it is better to start off with erythromycin except to have specific reason to use azithromycin. If we leave it blanket like that, you see that many people will start using azithromycin when erythromycin, a cheaper and more available drug, is available and accessible. Let's learn to start from the lower level drugs before we move on to the higher level drugs, except there's a specific reason why you want to use a higher level drug. Thank you.
Thank you.
Before we carry on, there is one question that that interested me. That said, in chronic pneumonia or infections, I can imagine why there is anemia. I can work it out, but I cannot work out why acute pneumonia should have anemia. And when I saw it, I said, well, that's interesting. But let us reason from the fact that, or from the point of view that pneumonia, especially bronchopneumonia, is a septicemic illness. It means that the child or the adult patient cannot possibly restrict the organism to a particular organism, organ or the lungs. So the organism is in the blood. If you have the organism in the blood, like the presenter said, some of them are even sequestered in the lungs. You can imagine what happens. Then some of the organisms release toxins. They have toxins. Some of them have toxins. Then the presence of organism in the blood, which is a septicemic process, or bacteremia, will definitely lead to the breakdown of some of the red blood cells. Because I still remember very well that my professors used to tell me that one sign of the presence of organisms in the blood is that there will be hemolysis. The individual may even become jaundiced. There will be anemia. So from today, remember that in acute anemia, in acute pneumonia, which is a septicemic illness, it is because of the presence of organisms and the byproduct of those organisms, especially those that release toxins, that will destroy the red blood cells acutely and lead to anemia and even jaundice. So there is even more reason, there is a very cogent reason for anemia in pneumonia. There is, and in the chronic conditions, there may be other reasons like nutritional and the others. But in acute case, the reasons are very obvious. Thank you. Then the issue of X-ray, sorry, I'm not going to say much after this. X-rays, I'm sure you look at the guideline, even the WHO guidelines says every child should not be exposed to X-ray, except you are suspecting complications or you are dealing with severe cases. So thank you. Please, X-ray is not for everybody. Thank you. So please, sorry, man, you cannot take it. Thank you very much.
Yes. Dr. Wilson and the Pediatric Respiratory Assembly. It's been very nice. I think to address Professor Sador's question, Dr. Peter had mentioned that 22 to 30-something% of pneumonia, lower respiratory tract, is due to respiratory syncytial virus. So hopefully that may be enough to advocate that is added to our immunization schedule, man. It's been a very, very
great. Is that Nigerian data?
Yes.
Is that Nigerian data?
Yes, it's in the chat.
All right. Okay.
Right. From hospital-based studies in Nigeria has shown that. So that will be good. Dr. Ali, for some say cannot be unmuted, but it's been a great day. For those asking for the slide, it will be in our WhatsApp group. And if you're not in the Pediatric Association, like somebody mentioned, it will be in PAN website at www.pan-ng.org. So we can access the slides there also. So with that, I'd like to say thank you everyone for being with us in another PAN webinar session. We thank the Pediatric Assembly of the Nigerian Thoracic Society for such a stimulating webinar, and Dr. Osarabo, my brother, I know you leading that pack. You've done a wonderful job. Thank you very much to the speakers.
Thank you, man. Thank you, man.
You.
Thank you, man.
On the chats. We thank Pan ESCO for being here and all our elders. I think at our peak, we got to almost 190. So till next month, it is good night and have a pleasant rest of the day.
May God bless you, man.
Thank you, my P.
Thank you all for listening to us.
Bravo, thank you.
Thank you all. Thank you all. Thank you. Thank you.
Thank you very much. Bye-bye.
Thank you, Arode, for joining.
Arode, thank you.
Thank you very much.
That's the Chancellor.